Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight are keys to preserving vision in glaucoma. And our speaker is Dr. Austin Lifferth, who graduated from the Indiana University School of Optometry and created a postgraduate residency in ocular disease at the Huntington, West Virginia Veterans Affairs Medical Center. Since that time, he's practiced in ophthalmology co-management centers for several years at Bennett and Bloom Eye Centers, a hospital-based setting at the Villages, Florida Veterans Affairs Outpatient Clinic, and now he's back home again in Indiana as a consultative optometrist with an emphasis in glaucoma management at the Center for Sight in Carmel, Indiana. Now, I do want to say that it is only coincidental that Austin and I are both working at Center for Sight. They're two vastly different practices, with a common name, right, Austin? He is a fellow of the American Academy of Optometry, a glaucoma diplomate in the American Academy of Optometry, chair of the glaucoma section of the American Academy of Optometry, and a member of the Optometric Glaucoma Society. He is a key opinion leader. He is a thought leader. He is an innovator and excellent clinician in glaucoma diagnosis and management. I think we're in for a really big treat to hear Austin talk about preserving vision in glaucoma. So, Austin, take it away.
Joe, thank you so much for the introduction. And Joe and Greg, really honored to be a part of your CE series. It was a real surprise when I found out we worked together, Joe. So this is wonderful. This is great to be a part of this series, and it's been fun to see already a lot of the participants, some familiar faces and names, and really appreciate you joining in tonight. I did want to say our concerns go out to our colleagues in Southern California with this rain and possible tornadoes. We hope you and your practices and families are safe. But I appreciate joining in tonight. When Joe and I were talking about it, he asked, well, what's my favorite lecture to talk about on glaucoma? And that's like asking, what's your favorite child? I mean, I love them all. But I feel like this is one that's foundational. I mean, this is one that of all other lectures I do, this kind of comes back to this main lecture. So to me, this is an important lecture as far as if we can understand and do these three keys, I feel like that makes us better clinicians, it's better for us as a profession, and it's better for our patients. So looking forward to sharing this tonight. Some keys that I feel like are important to essential in preserving vision in glaucoma. Don't have any relevant disclosures. And wanted to start with a survey. In one or two words, why do patients go blind? So it's been said that a problem well stated is a problem half solved. So what's our problem? Why do people go blind from glaucoma? If you're to put in a word or two, in your experience, what's the problem? If you see a patient with glaucoma damage and you try to look backwards, rewind the clock, what could have gone wrong? What may have gone wrong that could lead to this point for a setting like that? So why do people go blind for glaucoma? Like I said, if we can properly state the problem, we might be halfway solving the problem.
I mean, you can't see it on your end there, Austin, but we have about 48% of the people have already weighed in.
Great.
I haven't really done the polls this way, so I really can't see the answers. So I'm hoping whenever I end the poll and share it, we'll be able to see it. If not, we can resort to the chat box if we need to, but they're still rolling in.
Yeah, if we could do a word cloud, what it shows. And
So
I think
let me
this
see
is
what happens
worthwhile. At
here.
least the exercise itself is valuable, pondering what causes vision loss from glaucoma.
Okay, here we go. I'm going to end the poll. Looks like things have slowed down. I'm going to end it. I'm going to share. And I was able to click.
I think we'd probably have to go to the chat.
Yeah, we'll have to use that in your next one. I'll tell you what to do, Austin. Just unshare real quick.
Stop share?
Yeah, stop share.
Okay.
Can you see that?
Yep, that's great. So
I mean, the answers are up there, and
Yep, great answer.
Sure.
So a lot of it is non-compliance, optic nerve, nerve fiber, discretionary nerve fiber layer.
I don't
Yep,
know really
great.
how to get to the next page. So, I mean, first time we're doing it this way, so I don't know where to.
Hey, I appreciate trying. You know, this gives us an idea, and actually this points to one of the keys for us. So at least two of the three keys for sure.
Okay, go ahead and go ahead and do your I'll stop sharing and let you do your program.
Good. Yeah, so I think
Oh.
the comments you share that ties directly to
Here.
what we're seeing from the
Here, I'll
studies.
read them. I was able to figure it out. Let me read them to you. It says nerve damage to the nerve fiber layers, untreated, non-compliance, not taking care of their disease, not following treatment or late detection, nerve damage, optic nerve damage, three of those, atrophy, poor compliance, more nerve damage, they're not trying hard enough, late detection, untreated, damage to the rim. Some doctors fail to treat, not us, of course. That's what it says. And patient non-compliance. And the last one's non-compliance, optic nerve damage, and lack of follow-up.
You know, Greg, all those are right on. So actually I could end my lecture right now. That's exactly it. So, so to that point though, 40 some years ago, they asked this question, and you know, there might be sometimes an article that you read that just stands out and shapes your career, or a patient encounter that you have. This is one of those articles that for me was really intriguing. They asked the question, why do some people go blind from glaucoma? So 40 some years ago. And a lot of it is, like we said, basically three factors. About a third of the patients fail to seek treatment until after they're blind. So this is a delayed diagnosis. And they realize that they need to be diagnosed at an earlier stage. We need some way to create greater awareness. So about a third failed to seek treatment until they're blind. The other 2/3 were if they were diagnosed and were treated, either as insufficient treatment and or low adherence. So this is 1982, the article came out. And I thought, well, surely it's gotten better for that. About 8 or 9 years ago, a sequel article came out, asked the question, well, why do some people still go blind from glaucoma? And they found, similar to the first article, glaucoma is still undiagnosed. Glaucoma is still improperly treated, and there's still a lack of compliance. So here we are 20, 30 years later, and despite our advanced technology, our advanced understanding, increased education, there's still these three factors that are leading to loss of vision from glaucoma. And so I thought about that, and is this really true? Well, here's a patient I saw just about a year or two ago who came in with advanced glaucoma. Young patient, advanced nerve fiber layer loss, ganglion cell loss, and just unfortunately complete loss of vision in his right eye and a small central island in his left eye. He's a young patient, 38 years old. So I was thinking, how is this possible that with all our technology, that patients are still going blind from glaucoma? Because I've thought about that different studies have found that if severe visual impairment or blindness develops, it's usually within the first couple of years after the first glaucoma diagnosis. And they found that three things need to happen. Early detection of glaucoma, we need to have better treatment, and we need a solid working relationship with our patients. So they talked about some of those three things you discussed as well. You know, with that said, Relini and Dr. Fechner talked about three prognostic groups in glaucoma. This was interesting. They said that with glaucoma patients, there's those who do well no matter what we do. These are those patients who might be ocular hypertensive or low, early glaucoma, advanced stage. They won't lose vision in their lifetime. There are those who do poorly no matter what we do, maybe like this 38-year-old patient who was already at high risk for progression or fast progressor. maybe our secondary glaucomas, neovascular glaucoma, or pseudoexfoliative glaucoma. And this is important. There are those whose long-term outcome may depend on our management choices. So it depends on what we do. How well we do very likely determines how well they do. So there's some keys that we have that we can do, principles that can help with that. So from these articles, there's 3 causes of vision loss in glaucoma. Insufficient awareness. At some point, for whatever reason, these patients are undiagnosed. Insufficient action. Maybe they're diagnosed, but the treatment is insufficient. It's not meeting the target pressure range. And insufficient adherence. Diagnosed, maybe they're treated, but for whatever reason, there's insufficient adherence to that, and they're not in their target pressure range, they're not keeping their appointments, and the condition continues to advance. But from these studies, really the key to the lecture, these 3 keys, is all we need to focus on. To preserve vision in glaucoma, we need to make sure we have sufficient awareness as providers and as patients. So we'll talk about that. And this is a good overview slide. We just need to make sure that they're diagnosed. I really feel like we should be seeing more glaucoma suspect patients in our practice. Sufficient action. If they're diagnosed, we need to make sure that we're sufficiently treating them, that we're reaching the target pressure range based on age and stage, and to be proactive with that. The final one is making sure there's sufficient adherence. Making sure that there's education levels are there. We're removing any barriers that might affect adherence so we can have the success that we're looking for and slow down any progression. So these are the 3 keys. And think about, is there one that stands out to you that would be important for us to improve upon? Maybe as providers, we need to be a little more aware of it. Or for action, maybe we might not feel as confident or as comfortable in treating. Or the adherence, maybe we just rush out of the room, rush in, rush out. And there's not that doctor-patient communication that can improve that sufficient adherence. So I'd like to take the next little time, we'll talk about each of these 3 areas of ways that we can, as providers, these are keys to do that, to preserve vision in glaucoma. So with that, regarding patient awareness, sorry, Greg, here's another word cloud. We'll see what it shows. In 1 or 2 words, what do patients with glaucoma see? So if we're talking about patient awareness, sufficient awareness, there is some education that we can do to help patients be more aware of what to look for. And a lot of times patients might say that their parents had glaucoma, but they had it taken out, probably referring to cataracts.
Yeah, we have that one a lot, right?
Yeah.
So tell me, did you go blind? Oh gosh, no. They
They
was
had it
in the
taken out.
operating room for about 15 minutes and
Yeah.
took something out of their eye, put something in, and they could see again. Ah, I got you.
It's advanced procedures. So I feel like this is important because this is where, as providers, we can play an important role in our community or with our patients of what to look for. If you want, Greg, I can stop my share. We can see what show there, or if you want to.
Yeah, they're rolling in yet. It's, it takes a little time probably to type on their phones and so on and so forth. We've got 54 answers.
While you're doing that, I'm thinking about provider awareness, and we have our center is a referral center, and we have fortunately been blessed to work with a lot of area ODs in the area, and there's some practices that send us a lot of referrals for glaucoma suspects.
Okay, while you're doing that comment, go ahead and unshare it, and you can keep chatting, and I'll get this sharing. Keep your comment going.
There you go. Yeah, so some practices send us a lot of early glaucoma patients or glaucoma suspects. And I was thinking that I don't think they necessarily have more glaucoma suspect patients in their practice, but these providers are more aware of those patients who are more at risk for glaucoma. And I think as providers, that's a big factor as well that we'll talk about our role for it. I think we, with all the increase in numbers, we'll probably should be seeing more glaucoma suspects in our practice. Field loss, no change in vision, decreased visual field.
Yeah, for some reason, it doesn't allow me to scroll down here. It's, There we go.
Nothing different. Yep. Black spots, no symptoms. Last peripheral blur. They don't. You know, those are great points. And a lot of times, and that's what we'll find from some studies here, depends on the stage. I'm surprised that a lot of patients will come in perhaps with advanced glaucoma. They might still have that central island of vision seen 2025 or 2030, blurred vision, visual field defects. Yeah, these are great. Great surveys.
This is the third page, peripheral vision, missing areas of vision, blurred vision,
Mhm.
nothing until it's too far gone, gradual loss of vision, central and peripheral, normal, nothing, overall okay, some missing elements of the visual field. And missing spaces, subjective peripheral dimming, reduced visual field, asymptomatic, no difference till later stages, peripheral blur, usually normal. They see normal until they don't, halos. And the last one is nothing noticeable.
Yep. I think that's great. If we were to do a word cloud, a lot of it would be minimal, if any, nothing noticeable until late stages. Let me pull this back up for us here. Yeah, so I think what you described describes well what patients see. Interestingly, it's hard to tell what patients see. It depends on the stage of the disease. The more the advanced stage, the more likely the visual field loss. But it's hard to know how much field loss is required before the patients start to report symptoms. So this is under that section of sufficient awareness. There's a patient side, there's a provider side. And here's a patient I saw. This patient said they had a dark spot in their vision. Not the best picture, I apologize. But you can see the near complete vertical thinning. And when it's hit the rim there, and there's near complete thinning to the rim, they're not going to have much vision left in the corresponding areas. His complaint was a dark spot in his vision. Surprising. Here's another one. My left eye seems like he has a film over it. So for this one, you think, well, this is advanced. That might be a little bit different. They might be more aware of it. Here's one. My left eye seems like it has a film over it. You can see superior thinning, inferior thinning there, and moderate to advanced glaucoma, especially with the central defects. So a lot of times they'll have this advanced loss and it just seems dim or darker, like a lot of you mentioned earlier. You know, with the internet, if patients look on the internet and they find out what does glaucoma look like, here's what they see. They see a range, normal spectrum, normal vision, early glaucoma, advanced glaucoma. And is this really what happens? If a patient does have glaucoma, where does it usually begin? Usually it's nasally. And then the last place to go is temporally. Doesn't have that tunnel vision until advanced stages. So on the internet, there's a misrepresentation of what actually happens in early glaucoma. And I think I've done this myself, where I would explain to patients where the vision loss occurs with glaucoma. It might affect their side vision. Patients will say, I always check my side vision, it seems fine. But really what's happening is happening in the center part here towards the nose. That's where we're likely to see it. And if there's overlap with a good eye, they might not see that changes until it's significant. So I thought, well, maybe even if we went to the National Eye Institute, how do they describe glaucoma? And if you did a slider bar, you'd see that as you slide it across, same effect. We start to have this tunnel in vision. So the patients are looking for a tunnel vision. They're looking for a constricted area to tell if they have glaucoma or not. And that's something just misrepresented on the internet. But maybe that's something we could do as providers to increase that awareness more appropriately. So there's some really good studies out there that talk about, well, what do patients with glaucoma see? And if we look at this top picture with good contrast, full image, maybe they might have decreased contrast, some blurry spots, or some dark spots, or complete loss of it. Many times the patients with glaucoma, they'll say that the most common reported symptom, it wasn't the loss of side vision and tunnel vision, but just need more light. things were dim or they're more blurry. Those are most common symptoms, which can sound a lot like cataracts. They didn't really have any specific areas of visual field defect that they described. And in fact, here's another word cloud. We'll ask, well, how does glaucoma look? What are your main symptoms? And this is exactly a lot like what you guys described as well. Maybe missing pieces, blurred images, disappearing, fuzzy, unclear. But missing from this, no one said a tunnel. So even patients who have advanced glaucoma didn't say that they had a tunnel loss of vision. So that's what they should be looking for. That's not what's happening. And these are areas on their work cloud. Well, how does it affect your vision? All these functional lifestyle impact studies there.
You know, that Austin, that's actually very important in terms of functional lifestyle impairment. Often what I hear, patients come in, they tell me what they can't do. You know, they can't see the signs at night. And that could be cataract, or they lose their golf ball because they have very, very poor field, or they're losing their place when they're reading, and they don't equate that with a visual dysfunction. It's what they can't do functionally, and that sometimes is the key with advanced field loss.
Yeah, great point. You know, they might have friends who have the same symptoms. They had cataract surgery, they had it taken out, so they may underestimate. They may think they have cataracts as well, and delay awareness or delay diagnosis. So, great point. There's overlap, unfortunately, of these symptoms. So another study talks about, well, how does glaucoma look? If we were to give you 6 pictures of different key descriptions, kind of a forced word choice, how would you describe it? So with your glaucoma, here's the different visual field defects down here in level C. And even with advanced glaucoma damage in several of them, 54% said they're just blurred parts. So if you go over here to this side, there's just some blurred images there. 26%, the other majority, said not aware at all. Maybe some missing pieces, but none of them said black tunnel or black parts. So if they had to do a forced word choice, none of them showed those like we commonly are depicted on the internet. So this can be easily overlooked, and it's a great example of why glaucoma is a silent thief of sight. It just slowly develops, and we miss that. So they found that this shows patients with glaucoma, they don't have this dark area in their field of view. There's not that black tunnel. It's not the end of the black tunnel for that. We should tell patients that this isn't how glaucoma develops. It's not how it looks. And by self-treating or self-checking, they may be missing that factor. So this might be to apply for patients who have glaucoma, and we tell their children, make sure they tell their siblings or their children to have their eyes checked for glaucoma. That's something they can't really pick up in normal settings, but to have it checked for it. Here's one more picture of this. This one just came out not too long ago. This was an interesting app that shows what do patients with glaucoma see. And basically they're given this complete picture. There's about 3 or 4 feet in front of them, and then they're given an iPad that had the same picture on there. And they said, with this iPad, draw what you're seeing on this picture on the screen 3 or 4 feet ahead of you. And it showed what they showed. And with this app, they're actually able to depict what they're seeing. So with advanced glaucoma, just some missing pieces. It didn't have dark pieces like we would expect to see. This is just amazing to me that here's what the patients are showing very clearly. They didn't have a dark tunnel or missing pieces like that. So mainly they describe their defects as blur and dimness. Black patches, not dimness and black patches as classically described. So by stimulating it, what they could find, it shows just more blurred images.
You know, Austin, I think it's a great that you do this. I saw this a few years ago, and I don't know, 4 or 5 years ago, and it really hit home to me. And I'm glad that you're bringing it up and bringing it in tonight's webinar for us. You know, I think a good way that we can talk to the audience, and maybe we're going to bring this up, is we all have our physiological blind spots, and we don't walk around having these black holes in our vision. I think we all can relate to that. We all did that in optometry school, where we found our blind spot from our optic nerve head. and how our brain fills it in. And that's just kind of what it does here in glaucoma. So.
Yeah, yep, great point. Yeah, I appreciate it, Greg. I think it's
Yeah,
just
and
interesting that patients are underestimating how it's affecting their vision. Well, here's two more examples. Yeah, Joe.
yeah, as Greg was saying, that physiological blind spot is not a black spot. You plot it out with your finger, and you just lose your finger. What I like to describe, and these pictures here that are being shown, I think still are not. It's our best representation that they're trying to show. But what I describe to patients is I have one wall, it's beige. On it is a BIO headset and charging station right in the middle. I said, look, if you had really bad glaucoma, you would look at you see what you're there. But if you look at my wall with really bad glaucoma, you may not see that device on the wall. You don't notice anything different. It just isn't there. You just see a beige wall, but you're missing a key part of that visual field.
Yeah, that's great. I just think as you're discussing, many times when patients come in and we'll do the visual field defect, we'll show where it's located, maybe show that it's expanding. And on the visual field defect, it looks pretty ominous. That basically you're missing this top part of your vision. In reality, you still have a lot of functional vision. The brain's filling in the pieces, but it looks pretty, concerning for that. So I think there's still a way we can tell the patients what we're looking for. We're watching to make sure it doesn't get worse. But at the same time, you still have a lot of good function depending on the areas we have. It does limit it.
And I've always thought, Austin, that we've depicted this poorly. I mean, look how we designed the visual field. We're showing it to them on the grayscale as black, and we're telling them that you're not seeing black, but the visual field says black.
Yeah.
So it's almost contradictory. That's why it's so hard sometimes to educate patients so they fully understand, because we're depicting it very poorly. We have for ever since we've had this type of perimetry.
Yeah, yep. I think you're right. This might be the future where we do actually they look at a picture, they show us, well, what are you actually seeing? We'll see those blurred spots get more blurred or expand outward. It'd be neat to see if we could correlate that with our visual field testing somehow. So here's some real life examples. This was on one rainy afternoon. I was with my children. We were backing out of the car, and I stopped the car. I looked at the screen and I stopped the car, as any good dad would do, and said, children, this is what it looks like with patients with glaucoma. So just blurred pieces, missing pieces. It's not a dark tunnel. As you can imagine, my children were just so thrilled, excited to see that as they sat there blinking, motionless. It's like what a good dad would do, though, to tell them this is what would expect for glaucoma. The other idea is, a few weeks ago, I went running, some trail running. It was cold out. I had my sunglasses on, and I was able to recreate a inferior nasal defect with early central vision involvement. And as I was running with the glasses on, I could see how it would be challenging for maneuvering, balance, and stepping, especially when the lighting was poor. When it was bright out, it wasn't as noticeable. With both eyes, it wasn't as noticeable. So I could see how it'd be easy to miss these early visual field defects for patients if we're not looking for it and if we're not aware of it. This is what I think about when I go running sometimes, unfortunately. So just a connection for you. But it's out there. I think for patient awareness, it's our role as providers to make sure they understand what to look for glaucoma. It's not a side vision. So not only do we need sufficient patient awareness, but we also need sufficient provider awareness. And I think that one of the challenges is trying to find early glaucoma and its progression over time. On the earlier slide, the test poll, majority of us deal with early glaucoma, less with moderate, and even less with advanced glaucoma. And I really think as providers and colleague to colleague, that's our space. We need to make sure that we're really good at glaucoma suspects and early glaucoma. If we can be good at that, we can keep that base of that pyramid there, where it doesn't keep progressing to moderate to advanced glaucoma. We can really make that progression narrower and narrower. You just have a wide base of early glaucoma that providers were diagnosing and were treating. So here's a true and false. We'll see if this works better. A cup to dish ratio of 0.7 is glaucomatous. We said it's true or false. The reason I asked this is I remember soon after I graduated, and you may have seen this before, I saw a card that has different CD ratios of 0.1 to 0.9. And it had a spectrum of what's glaucomatous and what's not glaucomatous. And so it showed the different ranges, and around 0.6 or 0.7, it started to show it was glaucomatous. But it's more than just a quantitative value, there's qualitative features as well. So I'm curious to see what your thoughts are. If I just said this nerve has 0.7 cupping, CD ratio, would you feel like that's glaucomatous or non-glaucomatous? True. Okay, good. Yeah, so most patients said 80% false, 21% true. I think, both could be right. I'm not trying to make it a trick question, but I want you to start thinking about that there's more than just the cup to dish ratio. In fact, I would recommend, and we'll talk about a few things, to the last thing you put down as you evaluate the optic nerve is the cup to dish ratio. There's qualitative features that we need to put down first. And if we just put down the cup to dish ratio, it locks us in to that without really looking at the qualitative features. Good. I think two things that can prevent delayed diagnosis. One thing is, as providers, we may over rely on eye pressure levels. They looked at some patients who were previously undiagnosed from glaucoma, and they found that the main problem, the main concern was a lot of providers were falsely reassured. They put too much reliance on the eye pressure levels. I mean, they looked at the eye pressure, and I think that probably created a bias, and they didn't look at the nerve as carefully. Quigley said we need to kill the magic number. So forget 21. We know there's so many factors that can cause that pressure range, some of the things that go into the intraocular pressure, that a lot of times it might not be as reliable as we think it is based on the time of the day, the patient positioning, the provider technique, so many different factors. So I'd recommend, so we don't have the over-reliance on eye pressure levels, maybe look at your eye pressure reading of the patient after you look at the optic nerve. In other words, if we look at the pressure reading, it's 15, we may not look at the nerve as carefully as if the pressure reading was 25. So look at the nerve first, and then put all the other tests, including the vision, the intraocular pressure readings, any other ancillary tests, in the context of the optic nerve appearance. I've done that, and I found I've looked at the optic nerve a lot more critically, more systematically. So we need to take out that notion that anything above 21 is glaucomatous, anything under 21 is normal. So if we didn't have Goldman tonometry, if we didn't do tonometry, what would we do differently? This isn't necessarily a poll, but just for maybe rhetorical thinking. If we didn't have this tonometry, what would we do differently to monitor for glaucoma? Would we look at the nerve differently? Would we have a more systematic evaluation of the optic nerve? Try it tomorrow as you look at patients to look at the nerve first before you look at the pressure reading. I think you'll find that it looks a lot different in the context of what the nerve looks like. So as we ask this question, where are we as frontline providers on detecting early glaucoma? Glaucoma is not eye pressure. We know that patients can have high eye pressures, 20s, even 30s from the OAT study, and not develop glaucoma. We have patients in the mid-teens, and they can have glaucoma. Family history is not, that's not often reliable. Race isn't a determinant of it. It's a risk factor. Pachymetry or visual field defects or retinal nerve fiber defects. So these last two, this is important that not every visual field defect or OCT retinal nerve fiber defect is glaucomatous. So I like what Space said in his group that CD ratios, currently disc evaluation is not adequate because of three things. We're just maybe poor examination techniques, over-reliance on cup to dish ratios, and reliance on the image analyzers. Basically, they said that CD ratios should not be used. It's clearly outdated. They're not much help. The reason for it is they don't take into account any other qualitative factors, the size of the nerve, the extent of the rim loss, other factors that could be suspicious for glaucoma. So sometimes we just put down the CD ratio. I think we've stopped too soon. We're limiting any other qualitative systematic evaluation of the optic nerve.
Austin, as you had practiced it here in the state of Florida. In our Practice Act, that is actually mandated. We have to write that down, the cup to disc ratio. But I will also write anything probably above a 6 or certainly a 0.7. I'm also going to add in their description, I'm going to say normal optic nerve, and I'm also going to say large disc area, if it is indeed true.
Yep. I think that's great. We had to put down CD ratio. It's familiar. It's what we're used to doing, but not just only that. What other factors can we put down? So Joe got a good point. What's the size of the nerve? Is there rim thinning? Is there pallor? And I'll give you a helpful mnemonic that can help answer all those questions for you. We know with glaucoma as a provider, there's characteristic acquired atrophy of the nerve. So we know what glaucoma looks like. If it's a silent thief of sight, it always returns to the same spot. It always returns to the scene of the crime. We know exactly where to look for glaucoma. And there's different studies that are different qualitative features of what to look for, from Arnefeld defects, focal narrowing, progressive narrowing of the nerve on the rim, PPA, disc hemorrhages, PPA, large extent of peripapillary atrophy. But how we look at it determines on what we see. So we just look at CD ratio. If I said this was 7 or 7.5, maybe 8, it could or could not be glaucomatous, but we see this complete loss of the inferior rim consistent with glaucoma. So how we look at the nerve determines what we see. And that's what Dr. Krauston and his group found. This was interesting to me. They had two groups of people, two groups of subjects. One was ophthalmology trainees, one were glaucoma subspecialists. And they put on these gaze tracking goggles on their eyes, and they had them look at these nerves and tell us about the nerve. Is it glaucomatous? What's the CD ratio? And so forth. And for the ophthalmology trainees and then subspecialists, there's a different pattern. Let me show you a video clip of what that looks like. This red dot is where their eyes were going, and the red dot gets bigger where their eyes are staying. This first one is ophthalmology trainees as they look at the optic nerve. That's it. The second one is the glaucoma subspecialist.
It's like doing a field.
Yeah. Is that amazing? Yep. So the same nerve, different pattern. The first one looked at just the CD ratio. I think that's probably what happened. And then they ended there. The ophthalmology trainees just ended with a CD ratio. The glaucoma subspecialist had a systematic evaluation. They're looking at the size of the nerve. They're looking at the nerve on the rim. And then they extend outward to look for any retinal nerve fibrillary defects or disc hemorrhages. When I saw this, and I realized that each one of us, colleague to colleague again, we can look at the optic nerve like a glaucoma specialist if we have a systematic evaluation. Rather than just clumping together for a CD ratio, we can have a more systematic appearance. Pick up glaucoma earlier. This is all part of sufficient provider awareness. So there's some really key studies over the years that talk about how to examine the optic nerve in glaucoma. Different features, qualitative features, a systematic analysis, and all these go way beyond just a cup to dish ratio. Really great pearls. This number 4, Ios Jonas, that's really a key foundational article. If you want to look at the optic nerve differently, that's a good review. It's changed exactly how I look at it. It's just a comprehensive review of what things to look for glaucoma in the optic nerve. Anyway, some key factors. And I thought, is there a way we can have a systematic evaluation of the optic nerve based on these evidence-based review articles? So I came up with a mnemonic. I'm really excited about this, Joe and Greg, of how to evaluate the optic nerve in glaucoma. And intentionally, it has nothing to do, there's no mention of CD ratio in the mnemonic. So we're just going to spell out the word nerve. The first N is for overall, it's for nerve. It's for the overall size of the nerve. What's the size of the nerve, the overall appearance? Is it a large nerve? Is it a small nerve, like Joe was talking about earlier? How's the insertion look? That's going to be important for patients who are nearsighted myopic insertion, and the overall appearance. The second one is we look at the size of the nerve. Now we look at the extent. What's the extent of rim loss? Where is it at? How much is there loss? The key is to look in the 15 degrees. So we take the vertical, superior and inferior, look 15 degrees temporally to either the superior and inferior on the vertical meridian. That's where the hot areas are. I mentioned that if glaucoma is the thief of sight, it always returns to the scene of the crime. This is where we're going to see it, superior and inferior temporal. So we look for the extent of rim loss. This would be, in a sense, looking at the rim to dish ratio. So we talked about CD ratio. If you're going to do something, rim to dish ratio might be the better option because we're actually looking to see how much rim is actually left. So the rim to dish ratio, as you're looking at the rim to dish ratio, also look and see if there's any pallor. That's going to be the key to determine if it's a non-glaucomatous optic neuropathy. Glaucoma is one of the main causes of, one of the main most common optic neuropathies, but there's other optic neuropathies out there that can mimic visual field defects or retinal nerve fibrillary defects. And looking for pallor would give us that context. So look at the size of the nerve, the extent of the rim loss, looking for pallor. The other thing that's important is as you look at the extent of the rim loss, look for among patients who are myopic, nearsighted, the crescent moon sign. Meaning, is there a discontinuity between the inferior rim and the superior rim? Does this area here, this cupping, make a crescent moon shape because we've lost this rim connection from the inferior to superior rim? So in myopic patients, look for that crescent moon sign. That's a sign of glaucomatous damage as well. And this could be a lecture on itself, these different factors, but first look at the size of the nerve, extent of rim loss, checking for pallor, crescent moon sign among myopic patients, and then fan outward. Look for any correlating retinal nerve fibrillary defects. And sometimes they're hard to pick up depending on the pigmentation, the stage of the disease, but looking for retinal nerve fibrillary defects can help us see where we'd expect to see future visual field damage, future OCT damage. After retinal nerve fibrillary defects, look for all things vascular. So a couple of things we're looking for is what's the location of the central retinal vessel trunk? If it's eccentric, off to the side, let's say if it's displaced superiorly, inferiorly will be more prone to glaucomatous damage. So if you're thinking there's superior thinning, for example, see where the central retinal vessel trunk is. That might be a clue whether it's more likely to be thinning in that area. They're thinking that there's a vascular and structural role that the central retinal vessel trunk plays. As we go outward, look for any artery occlusions, look for any collaterals consistent with the more of a non-glaucomatous optic neuropathy. And then further outward, look for any attenuation that might be related to an old BRAO. And then finally, look for disc hemorrhages. These are literally red flags to look for that are signs of glaucomatous damage. And if we look for them, I think we'll be surprised the more we'll find. To that point, I recommend you always, when you have a patient back for an eye pressure check, make sure it's never just an eye pressure check. Look at the optic nerve as well. Look for these factors for disc hemorrhages. There have been several times where I'm really glad I looked at the optic nerve because I saw disc hemorrhage, and that might change the treatment. That might change the follow-up, bring other concerns about their blood pressure. So we've looked at the nerve, the extent of any rim loss, checking for pallor, fanned outward, look for any retinal nerve fibrillary defects, all things vascular. And then the E is edges for any beta zone parapapillary atrophy. If I could add one more, it'd be S. If there's anything suspicious, do some other testing. And the testing doesn't sync, another S there, then consider other possibilities. But the optic nerve, if we have a structural correlation, should show functional correlation of where to look for. So look and make sure those tests sync as well. This is a way that we can increase provider awareness just by looking at the nerve systematically for qualitative features. And intentionally doesn't have anything to do with CD ratio. CD ratio doesn't tell us much about these different factors. And in fact, the OCT is sure good, but it doesn't have anything about with parapapillary atrophy or for disc hemorrhages or for pallor. It's hard to differentiate that. So with that, you're thinking, well, we had all this great technology, Joe. I really need to be good at looking at the optic nerve. Here's an example of one with glaucomas. We looked at the nerve size, where there's possible thinning, disc hemorrhage. But here's the OCT, and it's all in the green. There is some asymmetry there, superiorly and inferiorly there, but it's all in the green. If we're not looking carefully, we might miss this muted thickness map pattern compared to the right eye, that asymmetry, this asymmetry of 111 to 142. But we might just look at the green and think this is a normal eye, especially if we didn't see that cup to dish ratio. Here's another example. Clear inferior temporal thinning, disc hemorrhage, normal OCT. Wait for it, I have another one for you, another disc hemorrhage, an OCT. So what we do and how we look at the optic nerve matters, meaning that we just can't rely on OCT testing to tell us if they have glaucoma or not.
Austin, that's very important to emphasize, and it's important, I think, to understand that we might be losing, not we, but professionally, we're losing the ability to read the optic nerve. Now, several years ago, when I was still at university, I ran a glaucoma symposium annually at the university. And I had a young fellowship-trained glaucoma specialist from Bascom Palmer. I mean, this is the top place. And he got in front of the audience and said, you may not believe that I'm a glaucoma specialist. I'm going to say this, but he goes, I'm not that good at looking at the nerve. He actually said, I'm not that good at it. I mean, I grew up on technology. I look at the OCT. And he was very frank about it. And he's one of the top minds in glaucoma. He says, I'm not that good at it.
Interesting. Well, yeah, I think knowing what we know about it, not every RNFL defect is glaucomatous. And so we just look at the OCT where we may overdiagnose and we may misdiagnose. There might be other causes of that retinal nerve fibrillary defect. Yeah, that's a great point. And I think if before you look at the OCT, as you bring back for testing, I'd always look at the optic nerve first. As I mentioned earlier, put every test you do in the context of the nerve appearance. So the intraocular pressure readings, the VA, even the OCT. So here's where we see and expect the thinning. And this is one which correlates, which is great. Love it when it correlates, increases our certainty. Here's another one, because I was looking for disc hemorrhages. The CD ratio doesn't look that significant. The rim looks pretty even. There's kind of shallow excavation and sloping inferiorly, but I did see this little disc hemorrhage there. So because we're looking at the nerve systematically, we're able to pick that up. I'll zoom in for you. And it did show surprisingly significant loss there, more than what I was expecting to see. I show that to you because we wouldn't have gotten to this point of doing an OCT if we hadn't been looking carefully for disc hemorrhages or nerve fibrillary thinning, glaucomatous damage on the clinical exam. These are the ones that scare me, where the CD ratio doesn't look too great, nothing outstanding, and there's not that apparent thinning, just maybe some shallow excavation or sloping. And if that disc hemorrhage wasn't there, I may have missed that one. But because of that, we're able to see it. So we just said that window of opportunity. These are the ones that scare me. So we have to make sure we always look for those factors for it.
I had one just like that today, Austin. Very, very, very faint resolving disc hemorrhage. If you look at the patient with a BIO, you call it a 0.3. When you look at it stereoscopically with a 90 up close, it was saucerized in about a 0.65.
Wow. Yeah, and Joe, I think the small nerves, if I give any advice, I'd make sure we look at any small nerve extra carefully to making sure there's no rim thinning there. It might be a small nerve that there's moderate cupping of 0.3 or 4. That'd be more concerning. So especially a small myopic tilted nerve, those are the tricky ones.
Mm-hmm.
I think we might be underdiagnosing these small nerves, overdiagnosing these larger nerves. We'd expect large cupping for large nerves. We'd expect small cupping, very small, 0.1 or 0.2 for small nerves, but not moderate cupping, 3 or 4 for small nerves like that. So that's a great point, Joe, looking at it with the 90 and really appreciating that saucerization. I think we're underdiagnosing those patients when they're smaller cupping like that. Great example. So in review for provider awareness, look at the nerve, look for any extent of rim loss, pallor, retinal nerve fiber defects as we fan outward, all things vascular, and peripapillary atrophy. So does how we look determine what we see? It does. I really feel like as providers, we can look at the optic nerve like a glaucoma specialist, and we could detect those glaucoma patients earlier and keep them and manage them at the low levels of early glaucoma or moderate glaucoma. You know, as you think about the different stages, early, moderate to advanced, when a patient is in those stages, a couple of things can happen. One is through proper treatment and proper diagnosis, early diagnosis, we can keep that patient in that stage so they don't progress to the following stage. Or the other thing can happen is they progressed without diagnosis or with improper treatment, or they pass away. So three things can happen. Our goal is either we keep them in that stage, or they pass away before they advance to that stage and they lose vision from glaucoma. So we want to keep them in the early stages, and that depends on our provider awareness and patient awareness, one of the big factors. You and I, we can look at the optic nerve like a glaucoma specialist systematically. So before you put down the CD ratio, look at all the different qualitative factors. We're trying to avoid this diagnostic delay, and it's two facets. Patient delay, maybe they have trouble seeking care for whatever reason, they can't get to the doctor, or they don't have insurance. But if they do get to our office, that's on us. We need to make sure there's no detection delay, that we're doing evaluate it carefully. We're not over-relying on eye pressure readings. We're looking at the nerve systematically. And then we can get in for the proper treatment and monitoring. So the first key in preserving vision in glaucoma is on us, making sure that there's sufficient provider awareness, and then doing what we can for sufficient patient awareness. Maybe there's a public service announcements you do in your community, or little webinars, in person-to-person, patient-to-patient conversation in exam rooms. We just to make sure that they're diagnosed. If we can diagnose them earlier, the prognosis is that much better. Any comments or questions? This would be a good place to stop or start. Joseph and Greg, you can now fact check me. Whatever thoughts you have there.
No fact checking, and there's nothing in the chat, so we're doing very well.
I'm trying to keep it as simple as possible. I feel like this is an important part, sufficient awareness. So after we diagnose glaucoma, we just have to make sure there's sufficient action. Is our treatment meeting our goal? Diagnosed and treated. And I think as ODs, maybe I'm alone in this, I felt it myself, but sometimes we might not be as proactive. Maybe we're hesitant to prescribe the sufficient treatment for that patient so they don't progress. For whatever reason, maybe cost, or for their age, or inconvenience. So what's our goal for glaucoma? And this to me helps sum up why we do the treatment, why we do the different testing. We're just trying to preserve their vision quality of life. So the goal isn't necessarily to lower the eye pressure, that's part of it. But our goal is to preserve the vision throughout the patient's lifetime. We want to make sure that they have the vision they need as long as they need it. I'll tell my patients that my goal is to make sure that you don't ever know, vision-wise, you have glaucoma. You'll be coming for testing, you'll be doing treatment, but I want to make sure that you're never really aware of it. And that's going to take regular visits and proper treatment to get to that point. So there's different things we look at to making sure we have the proper diagnosis and make sure they're treated sufficiently. The functional impairment, what's their residual life expectancy? Really comes down to age and stage. What's the age of the patient? How healthy do they look? How long do they expect to live? What's the stage of the disease? We want to make sure that we're more proactive for younger patients. In fact, I'd be more concerned if a patient was 82, or I'd be more concerned about a patient who's 52 with early glaucoma than I am with an 82-year-old with early glaucoma or moderate glaucoma. There's more time for that disease to progress. And the challenge with glaucoma is it's progressive, it's unstable, it's chronic. So we have to have that regular treatment or testing and evaluation. Here's an interesting graph. It's a whom to treat graph. And there's value in almost putting your patients on these different areas. And I think when the interesting and challenging and rewarding aspects of glaucoma is each patient's different. They present at different times. And they might have early glaucoma, slow progressing glaucoma, adherence to treatment. They'll never lose vision from that. This is basically a whom to treat graph, and what we're trying to do is making sure that they don't hit this floor of blindness before they pass away. It's been reported like they might call it the wall of death and the floor of blindness. We want to make sure they have the vision they need as long as they need it. And there's a few different scenarios where this patient here might have been diagnosed late or rapid progressor. This patient was diagnosed with maybe late, but was able to prevent it at a later stage in their life there. And for number C, this is interesting that maybe they're diagnosed, but maybe not treated sufficiently, and they still lost vision. So there's those three prognostic groups: people who do well no matter what we do, people who don't do well no matter what we do, and there's this whole group here, maybe D and B and C, where how well they do depends on what you and I do. We try to put the patient on their age and their stage and try to do what we can to prevent further vision loss. We want to flatten that slope. And there's different risk factors we can look at for that. We might be able to accept a higher target eye pressure if it's early glaucoma and a short life expectancy. But if they have a long life expectancy and more advanced glaucoma, we have to be more aggressive. And to not be afraid to be more aggressive. And add the treatment that's needed, refer to the specialist if needed. We want to keep that glaucoma stable, flatten that slope. Here's some ideas, is generally speaking, if it's ocular hypertension, to get the pressures below 21, mild glaucoma below 18, moderate glaucoma below 15, and advanced below 12. So each person is different. This is just a general principle, but that's kind of what we're looking for. We want to have an idea of what's our goal target pressure range. And by setting a target, it's a dynamic pressure range. We're trying to find out, well, what's the patient need? This number is always being reevaluated. Once they come back to the visit, we're looking at the nerve, the testing, see if we change it. And there's this idea of first line treatment, but really it's more first choice treatment. What's the best choice for this patient that's going to provide the most effective option, sustainable option, tolerable option, cost-effective option? And we look at the big picture, patient characteristics, the drug properties, the cost, efficacy. And in general, what we're trying to do is download all the pieces of data, find out what the stage of glaucoma is. If we put them on the graph, how likely are they to progress to glaucoma? So we download all the pieces, and then we try to make them fit, making sure that there's certainty in the testing, that there's correlation that's reliable. And then we balance the risks of treatment versus the benefits. Should we observe? Should we start treatment? Should we initiate or add more treatment? And this is a mutualistic decision with the patients there. And afterwards, then we agree upon a plan. That with the patient, after we've presented this data, they've done all the tests, we've presented the data, here's where we're at. Based on your age and stage, here's a recommended treatment plan. And it's key, I think this is key, to make sure they agree with the plan to maximize adherence. And then we push start. We start it. And it's repeated. Every time we see these patients, we repeat this process. Download data, put the pieces together, making sure they're fitting, start the treatment, and push start. Each of these symbols are important. I think if we were to find where there might be some errors, it might be this area here. Download the data, we might not be testing as much. Meaning we might not be doing enough visual field testing or OCT testing, or the results we do have may not be reliable, and we're misdiagnosing it, so they're not fitting together as the pieces. Each symbol is important, but I think as ODs, we need to make sure we have all the right data. I've never regretted having another test of visual field to increase certainty. I try not to make a decision based on one visual field or one OCT. And even intra-office visits, just repeat the OCT. In fact, I've had a couple of the last few weeks where the first signal strength, they're undilated on the OCT, poor signal strength, and it showed a supratemporal visual field defect. It didn't correlate clinically because we're putting all these tests in the context of the optic nerve evaluation. It didn't correlate clinically. So I said, let's run it again. Now that they're dilated, put an artificial tear in, and they ran again, and the visual field was clean, or the OCT was normal. So I may have overdiagnosed based on that piece of information and overtreated, when for this glaucoma suspect, we can still keep watching it. So even in between visits and during the visit, check the pressure again, do the OCT again if needed, if we have low signal strength. We can only make good decisions if we have good data. Good data gives us good decisions. So here's an example of a patient that saw not too long ago. Some different factors. Overall healthy, higher blood pressure, higher BMI, no known allergies. He came in for a comprehensive exam, a new patient. He had blur for the last 6 months, gradually worsening. Sure sounds like cataracts. I think that's what we all can think about it. That's probably what he was thinking. No eye history, no medications, no pain. Vision corrected to 20/20. Normal eye pressures, average PACs. Slit lamp looked fine. Valid fundus evaluation. I'll give you the CD ratios. Remember how we talked about how maybe CD ratios just don't give us the information we need, but I wouldn't think anything suspicious for these CD ratios if that's all I gave you. Everything looks stable. Maybe some early cataracts, but nothing significant where needed surgery, corrected well. So, Joe, this one's for you. This is kind of like we were talking about, where it's a small nerve. It's real easy just to look at color more than contour, but look at this thinning down here.
Yes, and the tessellation makes it much more difficult for you to assess any focal nerve fiber layer defects. I think this is where the OCT will come in handy.
Yeah.
But you're right. If you have a 30,000-foot view, you're looking at maybe fairly small cups. I think that if you look closer and go through, somebody asked about notching. We want to be looking for notching or focal neuroretinal rim defects. You know, once we get up close stereoscopically, we can really probably assess that and see how much risk those nerves are.
Yeah. Yeah, so this is one that on quick glance, we may have missed this. Look at CD ratio only. Like I said, 0.45 really doesn't tell you much about the CD ratio or the optic nerve health, the risk of glaucoma. But you can kind of see that there's that loss of kind of excavation as well, thinner rim. There's that asymmetry between the two eyes. And that's where we showed an OCT, advanced, dense nerve fiber layer loss, almost to the rim there, inferiorly.
Yeah, and the tessellation really prevents you from really seeing that clinically.
Yeah, and I think that's true. So the key then is to make sure we always look inferior temporal and superior temporal. To not get distracted by any other features, but that's where the early glaucoma is going to show up. And if we're looking in those areas, we'll pick it up. So you see the OCT correlates with the GCA on the right eye. This is some ERM thickening. That's where we have this abnormal finding there. So just like RNFL defects, not all of them are glaucomatous. Not all ganglion cell complex defects are glaucomatous as well, but this correlates inferior temporal thinning and then near advanced glaucoma in that right eye. Yep, these are the ones that scare me, where if we look too quickly and just look at the CD ratio, we'd miss something. So here's a patient, 78 years old. For fun, I zoomed in. Here's the 10-2 over here. We took this area here, zoomed in, and that's where it gets. So it does show central vision involvement in that right eye. Left eye, fortunately, was normal. And I think this is a good example when you do 10-2 testing. If there's any inferior temporal thinning on the nerve, if there's inferior RNFL defects and correlating ganglion cell complex defects, or any defect in the central 10 degrees on 24-2 or 30-2 testing, I'd consider doing a 10-2. It zooms in that area, tells us and the patient helps us better appreciate how much glaucomatous damage there is. So what would you do? Here's the data. We're downloading the data, putting all the pieces together. What's our goal? How can we sufficiently treat this 78-year-old patient in this right eye for the glaucoma? In this case, maybe we're down this way. He's healthy. So there's a big chance that he's heading this direction, reaching its functional impairment, especially in his right eye. So you think about what's first choice treatment versus first line treatment. First choice might be a beta blocker for cost or prostaglandin, or first line treatment, maybe SLT or MIGS or surgical. The question is, how do we know if the treatment is sufficient? Well, we just repeat the tests. We start treatment based on what's best for that patient, and then we bring them back. We repeat the visual field, we repeat the OCT, making sure it's stable. It's kind of like a new baseline once we start the treatment. So we download the data, put the pieces together, find the best treatment option, agree with the decision, and then we push start and we repeat. So making sure we're sufficiently treated to prevent functional vision loss. Unfortunately, that patient was late in the stage, so we have to act pretty quickly, pretty aggressively. Any comments now, Joe or Greg? Looks like there might be some questions in the chat as we go this
Well,
final
my comment is, people wonder, well, how can you not treat a person like that sufficiently? I think that we have to have a situational awareness. And one thing that's always been very important to me is, what is the highest pressure we've ever registered on a patient? Knowing that we're never going to know all the pressures, but what is the highest that has been recorded? Because you had something earlier on Paradigm under 18, and everybody seems to like that number, 18 or lower. And you might be cruising along great, 18, 17, 19, 18, 18, 17. And you think you're doing great, but when you go back and look and found out that their peak pressure is only 20, well, that pressure of 18 probably is insufficient. So that's where you can end up with some trouble.
Yep. Yep. So don't
Yeah.
look at the pressures. We lead it. That's a risk factor. That's how we control. That's how we can gauge drop or treatment efficacy. But there's just more to that than just the eye pressure. For that.
Hey, Austin, my comment that I wanted to point out, you did a great job. I want to echo is, glaucoma is a disease of the macula. The macula, don't forget, everyone out there, is 5.5 millimeters wide. You can say that when it gets advanced, or some advanced cases, or cases where I would consider it being advanced, would be when the fovea starts becoming involved. You're getting in really close to that center of fixation. And to me, that's when we want to be a little bit more aggressive in our treatment. So we know that glaucoma is a disease of the optic nerve. It's an optic neuropathy. It's the #1 optic neuropathy. But let's also call it a disease secondary of the macula. And that will help us maybe with our being a little bit more aggressive in some of these cases.
Yeah, that's a great point. Yeah, thank you. Just think about that. Greg and Joe, if the patient came in and you saw this and this is all you had, pressures were 18, would you start this patient on treatment right away, or would you bring him back, like Joe was saying, to get another pressure reading? So let's say we did an OCT, we had photos. Is that enough information for you to start treatment?
OCT and photos, I'd want the visual field. You can get that on another day. And of course, we're going to need pachymetry, gonioscopy. That might be 1 or 2 more visits. And I know it stretches things out, but it gives you a chance to get a few more pressure readings in there. And keep in mind that if you start treating this patient and you're going to follow them for a period of time, there'll be probably periods where they come in where they ran out of medicine, or they lost a follow-up, or they come in untreated. And sometimes that's actually beneficial. And you may find out, well, gee, that was a 25 pressure.
Yeah.
Or
good point.
you can see how high they go. So we don't have to always have that very first reading. It is a marathon, not a sprint.
Yeah.
And to answer your question, Austin, is it enough there to start treatment? Sure. Probably early in my career, I would be like, oh my gosh, there's damage. You can see the damage and we got to start treating now. And I think as we become experts and mastery into this type of condition, just like Joe says, we kind of slow things down. We've got time. What happens if they didn't come in for 3 months or 4 months? We'd still be in the same situation. As long as it's not advanced, we only have a few, nerve fiber layers hanging on. I think we have time to gather that information, inhale, exhale, kind of digest it all. But to answer your question, is that enough to start? Yes, but probably we could slow it down.
Yeah. Yeah. And that's the reason I'm asking it, because I think this is one of them where I did start treatment right away. I felt like in my mind, sure, it'd be great to have a few more readings, pressure readings, different times of day, more information. But I feel like with this information, this is glaucoma. We know what it looks like.
Oh, yeah.
It has advanced loss. It's deep loss. I'm concerned when it's almost to the rim. So I did start him on treatment, even though the pressures, one reading were 18. I know there's value in getting different readings, different tests, but for that setting, I felt like I went in and started treating one on that.
No, I think it's a very viable option.
Good. So we talked about sufficient awareness, the 3 keys: sufficient awareness, making sure the patients know that, and as providers, we're always looking for it. It's never just an eye pressure check anymore. We're always looking at the optic nerve. Sufficient action, making sure they're diagnosed and sufficiently treated. Looking at age and stage and trying to make sure they don't know they have glaucoma damage as much as possible. They have the vision they need as long as they need it. The final one is sufficient adherence, making sure that we're going to start treatment, that it's something that's going to be sustainable, that they're going to keep taking every day so we can prevent further vision loss. And there's different barriers for that. Like what our very own Murray Fingret said, that patient adherence is a wild card in the deck for controlling glaucoma progression. And I think each of us have seen that before, where they may be doing great, and then maybe they lose their job or they lose their insurance, they take a vacation, their health changes, something changes, then all of a sudden their glaucoma progresses. And we could be the best providers, have the best equipment, timely diagnosis, but if there's not that adherence that we're looking for, then we've lost that ability to control it. So here's another poll question. True or false, I recommend SLT as first-line therapy in appropriate ocular hypertension and glaucoma patients. So this might be easier in patients in states where you have expanded therapeutic privileges. But even if not, do you have a comprehensive ophthalmologist that you can work with, a good relationship, to consider SLT?
And as this poll was running, someone made a comment about, I agree with the importance of running tests. However, in our state, many insurances plans only allow these tests once a year. Yeah, I'd say circle back on that. I've been the third-party chair or part of the team for the last 2 decades fighting for parity access and discrimination in Pennsylvania. And we have solved a lot of these. Visual fields, you're probably even in your state, able to get away with some of the testing. It's usually the OCT where they start limiting. There was some of that talk out there, but the states have a lot of third-party chairs, even on the ophthalmology side. But you might get a little bit limited, and with glaucoma, 1, probably 2 is the max, depending on what's happening with the pressure. But, in those advanced cases, I'm doing visual fields every 3 to 4 months. So that's just responding to that comment for you there, Austin.
Yeah. Greg, that's a good point. I mentioned how with good data, we can make good decisions, but we need enough data to make good decisions. And sometimes that means a few different tests over a few different visits to get that information that we need. There might be times where maybe it's not covered by insurance, but at least for the patient and I, we have the information we need. Maybe we write that one off, but many times I haven't had any trouble as long as I have a little paper trail as well that I'll put in the chart: visual field unreliable, or visual field suggests new defect, repeat in 1 month, or OCT suggests progression, repeat and next visit. So there might be some times or pushback, but I guess a question to answer your question is, when do you want to diagnose glaucoma? Do you want to do it later because we don't do tests as often? Or when do you want to detect progression later, or do you want to detect it earlier by repeat the testing? I think there's balance between insurance coverage, but also the disease state. For disease is unstable, more testing is helpful sometimes. That's a great question. And I know it's always challenging to balance testing, but also the information we need. Good. So we're almost split. Wow. So I recommend SLT as first-line therapy. About half said yes, half said no. I'm curious, for those who said yes, I wish this would open up to a discussion why you would do it for sure, and those who said no, why you'd say you would wait. I suppose you'd probably do topical therapy first for a patient like that.
Well, if they want to put some of those comments in the chat box, we can certainly monitor those and kind of let you know as they roll in. So if you want to use the chat box, and you can continue, and we'll let you know what do we get some of those answers there.
We can have a nice counterpoint discussion with 100 participants. So 101 participants. I think it's a value, and lately we know from really good studies that SLT can be effective. I think another way to phrase that question is, if you were diagnosed with glaucoma, what would you like? What would you feel would be best? And insurance aside, if it was covered by insurance, what would you think would be the best, most sustainable, most tolerable, most effective way to treat glaucoma?
Yeah, some are starting to roll in, and one says studies showed is as effective as drops, I think is what it said. It moved on me. Studies are effective as drops. This doc, our colleague, has poor access to SLT, more assured of treatment compliance with SLT. So you're getting that assurance and maybe adherence that we were talking about. These are moving, so I'm trying to control them as they're rolling in. As the patients have much better compliance with 0 drops versus any amount. SLT for never treated patients. SLT is effective and no compliance issues. So I think we're kind of honing in with the SLT side on the compliance. You could add to that maybe the safety to the ocular surface, the chronic. It was pretty cool at the OGS this year, Austin. How much we've been going for how many years, and they really started focusing on, hey, look what we focused on the optic nerve. Look what we're doing to the front of the eye. So that was kind of cool to see that happen. So.
Yeah, great points. I think the light studies really brought that down, and other studies in the Cochrane review showed that there's benefits of doing SLT. I think for settings like this, if we can take as much of the treatment out of the patient's hands and do it in the office, the better. I'm learning, I'm better appreciating that. There's this idea that I'm striving for. It's independence or adherence independent IOP reduction. So if we can make the adherence part of it, if we can lower the eye pressure without any dependence on adherence, that's what we're trying to do. And this is one way to consider for that. And not only does it help out with adherence, but also helps out with ocular surface, like you're talking about. It's been neat to see that when some glaucoma lecturers or specialists taking their pulpit time and talking about dry eyes. I never thought I'd see that 10 years ago or 5 years ago, but I think we've become more aware of the ocular surface and the quality of life. This is one of those factors that we can do as providers to not only control the disease better, but also maintain the quality of life. So I'd recommend you work with your ophthalmologist and see where their comfort level is. As far as the discussion goes, this might be a setting where you download the data, present all the pieces, and it might go something like this, where I'll tell the patient, Mrs. Jones, looks like with this information, you have early signs of glaucoma in your right eye. Fortunately, it's not affecting your sight vision a whole lot right now, but we want to keep the pressures low. One way to lower the eye pressures is by using eye drops. You take it every day. Another way is to do a type of laser procedure. It's like what I just did. So after I've done gonioscopy, I found this is a good window to it. It's like what I just did with a lens like this and machine like this. We use a laser to help the natural drain path of your eye work better. And that's how I present SLT. I'll say the word laser, but I'll show them exactly how we'll do it. Takes a few minutes, doesn't hurt, doesn't affect your vision. You get up and go. I'll often say it's, in my mind, a more natural way to treat, to treat glaucoma and to lower the eye pressure. And then I let them make that decision, but at least they know about it. Sometimes patients, once they know about it, they still want to try their drops first. In their mind, maybe that's their step. We kind of go at their own pace to find out what they want to do and how much they want to do. But at least they know about it, and we see them back in a few weeks to check the eye pressure with the drops, or a few weeks for the SLT. But I think how we present it, the explanation is important, and to consider what would you rather prefer for a setting like this if you had to take drops. So great points. I appreciate the discussion and the comments there. It's interesting that there is a lot of barriers. This is where we're kind of getting the art of glaucoma. The first two keys talk about the science, a lot of it, but this is more the art of it. And there's the patient perception. They'll take their medication if they perceive that they're susceptible to the disease, if the disease is severe. If I take this medicine, are there benefits with it? These are all perceptions that we have to kind of address, and each person's different depending on their health literacy, their social economic status, their age, if they're single or divorced, or if they're married, if they have something to live for, so to speak. So they're saying that if the patients believe these things, they're more likely to keep their follow-up appointments. They're more likely to take their medications. And the fact is, for us providers, we really aren't very good at detecting adherence. Budens and their group said that we do a poor job at detecting non-adherence. We're probably assuming more than is actually happening. And in fact, our attitude has been shown to play a large role in that. If we're nonchalant and come across as non-caring, that might send a signal to them that it doesn't matter if they take their drops or not. If they just take it a few days before they come in for their visit, which is real common, and not take it until then, pressures are still okay. So I think our attitude plays a big role in that. In fact, if we can change our behavior and show the importance of adherence, that changes the patient behavior. So by asking non-threatening, open-ended questions, these are ways we can show that our concern. If I'm typing on my keyboard and I'm asking Mr. Jones, do you take your eye drops, yes or no? He will say yes. A lot of times they just want to please the provider. But if I ask him and say, I know, Mr. Jones, one of the hardest things about taking drops for glaucoma is just remembering them. A lot of patients forget to take their drops. How often would you say you miss them? Or what are some of the challenges you have when you start taking your eye drops? If there's times you miss them, what are some factors? So open-ended, non-judgmental, patient-provider relationship, trying to build that can help us identify those treatments for it. And here's the problem with non-adherence. We have unstable eye pressure, but more than that, we have progression. Glaucoma damage and visual field progression, the factors of non-adherence. So it's important that they're adherent. And it makes sense, it's intuitive, but if we're not adherent, we don't get the intended or full effect of the treatment. And this is just human nature. So maybe there's adherence pie. If we had full adherence, we're likely to have complete treatment, full benefit. If we have incomplete adherence to any degree, we just won't get the full benefit. Sometimes, and we can think of good examples of this, let's say if I want to lose weight or become more in shape, I can't go to the gym just once a week. I can't expect the full benefit unless I have full adherence. That's the same thing with any medication. Partial adherence leads to partial benefit. And there's a spectrum. Maybe patients who take their drops every day at the same time, that's perfect. Maybe every day, maybe within a time period of an hour or two. They might miss a drop a month, a couple drops a week, several drops a month, or not at all. And there's this whole spectrum, this pie chart of adherence. So in a spectrum, we'll get the full benefit if the patients are adherence, whatever it may be. But unfortunately, what happens is even with moderate or non-adherent patients, even as human nature, we think if we're still down this range, doing our exercises once a week or not eating well every day, we still would expect a complete benefit. It's more the art of it. And this is easy to do for asymptomatic conditions like glaucoma, but even with symptomatic ones, it can be a challenge. I remember several years ago, I had vertigo, pretty symptomatic condition, and I forgot to take my medicine. So I shouldn't be surprised if I still dizzy. I shouldn't expect the full benefit if I did have full adherence for that. And this is for a symptomatic condition. So imagine one that's asymptomatic. So it shows that we know that the more drops a patient takes, their adherence drops. This is that wild card in it. And there's been a trend to try to reduce the drops. Maybe glaucoma isn't so much of a medical condition over time, but it's turning more to a surgical condition, from SLT to MIGS. Here's an example of a patient who was on 3 different medications. And the pressures were pretty well controlled. They did start to climb up a little bit more. And actually, I switched it to preservative-free equivalents. And not only did their pressures get lower, but their ocular surface got better. Probably because their eyes felt better, their adherence improved. So doing what we can as providers to provide the most effective, sustainable, tolerable treatment can help with adherence. And we do know, this is a great graph to consider, that the more drops you took, the more adherent the patient was, the less likely a visual field loss. If you miss more than 2/3 of your doses, They found from the collaborative initial glaucoma treatment study that you lose that vision. So it makes sense. If you take your drops and the target pressure is reached, there's adherence, you're less likely to lose vision. So there's a critical need to help our patients understand that improving the glaucoma adherence. In fact, maybe we don't need more drops or more medications or more treatment. We just have to improve adherence. Maybe that is the main factor to reach the goals we're looking for. So adherence is a big word, a big factor in our care. So in your mind, if you look at patients with topical adherence, what is the most common barrier to adherence? What are some factors that might keep it so they're not taking their medications? If you ask them what are some problems, what would they commonly say? So I think this is our last polling question, last word cloud question.
Yeah, Austin, that that information you got from when they mined out data from SIGITs, I think maybe an even more recent paper came out and they looked at people who were getting daily reminders as part of the study. And the ones that were quote unquote 100% compliance, they lost vision at the same rate as aging. So medicines will work if they are used.
Well, that's powerful. And it sounds intuitive. It makes sense. But to see the data like that. And I love to hear patients say that they found a routine. And I'll tell them that routines preserve vision. So just taking your drops every day at the same time, that's going to keep your pressures low. If it's sufficient treatment and you're adherent to it, we're going to keep your vision where it's at. So routines preserve vision. It's empowering and wonderful to hear when the patient says they found a routine. So pair it with their different medications. Good. I'll stop and share this if you like, Greg.
Mm-hmm.
Yep, that'd be perfect. Just let me see here, get a few things out of the way and find out where my share button went. There we go. And this should do it.
Okay, most common, fall asleep, forgetting, don't feel good.
Cost, inconvenience of use of drops, remembering, expense, forget, remembering to use them, memory, forgetness, forget it, forget discomfort, can't get it into the eye. That looks like 3. So forget discomfort and can't get it in the eye. Time constraints, remembering, eye drop sting and eye gets red. All right, let's go to the top here. Concern, costs, cost of meds and experience. In my experience, lots of people without insurance. Remembering, busy schedules, difficult to maintain routine, cost, remembering, comma, establishing routine or the side effects, establishing routine or side effects. They forget, get bored in compliance, no consequence other than what the doctor say or will be of consequence. Cost, difficulty using, compliance, forget, remembering to use the eye drops, a lot of forgetting. So that would have been big.
I think that's a trend there. As we look at it, that's one of the main factors is forgetfulness.
Attention, too many drops. There's it is, remembering long schedules, not sure they were getting drops into their eyes, compliance. Affordable was another one, expense, there's cost. Patient education, not knowing the importance of compliance and permanent consequences. There you go. So education. Eye irritation, traveling, loss of insurance coverage. So that'd be maybe some cost or inability to properly insert the drops. We have technique. Cost, side effects, irritation, stinging. There you go. So stinging, uncomfortableness, and then back to cost, eye irritation, and remembering. Administering, poor compliance, due to asymptomatic condition, forget, comma, cost and comfort. Most common is just forgot. Most addressable is too expensive. Cost, instilling, remembering, poor education, money, discomfort,
Hmm.
adherence, cost, stinging, cost. Missed my eyes. There you go. Cost, I forgot. And let's see, one more. Ease of application, laziness, hard to remember, inability to instill drops properly.
And I think that's a very important one because we have a certain bias as eye doctors. Both optometrists and ophthalmologists, from our very first day of training, we're putting eye drops in people's eyes. We just assume that they know how to do it. And that's a bias I think is wrong. When I've got a new glaucoma patient, I will actually take a bottle of artificial tears and demonstrate how a way to do it so they can understand. But I think that's
Yep.
one of our biases.
Yeah.
I think those are great points, and the technique makes a difference. I'll show you another slide about that. Maybe we'll jump to that one with the time that we have left. One of the comments was many of them were forgetfulness. That's one of the main factors. So if we can find a way for the patients to find a routine, pair with other medications, pair with the time of day, reminders on their phone, all those different factors that can maybe overcome that barrier. The other one was talked about, I have a lot of, excuse me, they have to take a lot of drops and they're not, it's hard to take all of them. I think to that point, I wonder if we still, in our day, still need to do eye drop sheets. You know, when I graduated 20 some years ago, I remember writing down a piece of paper, you have to take this drop tonight, this one 2 times a day, this one 2 times a day. That's a lot of drops. If we're at the point where we have to give them a sheet, that's too many. Meaning we can, now with what we know, we can do SLT in place of 1 drops, or there's a lot of standalone mixed procedures. We can move more to a surgical treatment for this condition rather than depend on drops so much. And if we can identify these barriers, like you just talked about, they get better results, more control of their disease. So great questions there, great comments. So these are all barriers, they're physical barriers. This is kind of art of caring for glaucoma. From different studies, they talked about things you mentioned. Well, maybe I wasn't happy with my doctor's care. I didn't have to take them forever. You know, unfortunately, there have been times where 4 months, 6 months, a year or 2 into taking care of a patient for glaucoma, they'll ask me again, why do I need to take these eye drops? And why am I taking these eye drops? Or do I have to keep taking them? So somewhere along the line, I've done a poor job of helping increase their understanding, provide the education they need of why they need to take their eye drops. So I'm glad they asked that. It is revealing to me I missed some opportunities. And that happens on the first one. Sometimes there's life events that happen, travel away from home, maybe they lose their job. These are all barriers. Another barrier that just came out in this article, just dropped this past week or so, more comorbidities, so the more health conditions they have, that increases the burden of this chronic disease, and that decreases adherence. So maybe there's some red flags of patients who we think might not be adherent, those who have other comorbidities, those maybe lower social economic status, poor health literacy, those who may be single or divorced, all maybe if they're depressed. Interesting factors of ways that they can affect our adherence. Well, let me go to a few things with the time we have left here. I want to show you a video that talks about technique. And to Joe's point, that's exactly right. Here's a video that I took several years ago of 4 or 5 patients, long-established glaucoma patients, and they're taking their eye drops. And I asked them, well, can you show me how you put in your eye drops? Because technique is a big factor for it. If we have poor technique, we can have the best medications, but if it's not getting the eye, it's more likely to cause unstable pressures. Let's see if this will play for you here. Is that playing, Greg?
Oops, I was muted. It
It
is.
is.
Good. So here are different comments. In your own words, how would you describe it? And these are patients that we mentioned. These are seasoned glaucoma drop takers. This might be that patient who says they run out of drops after 10 days or 15 days, and then they go without drops for 10 or 15 days beyond that before the refill comes through for the pharmacy. Don't worry, this is all a new bottle. I gave them each a new bottle of artificial tears. And think of the risk of increased contamination, waste.
Mhm.
And with more than one drop, how much is actually get in there? That's probably those patients who come back with pressures high. They say they're taking their eye drops, but it's really just washing right out. So it's revealing. I invite you to, if you have patients whose pressures are fluctuating, give them an artificial tear bottle, like Joe said, and show them how to put it in, or ask them to show you. All these are different factors that can affect the disease stability. And because of poor drop technique, these are the different risks that relate to that. More waste, more risk of infection, less pressure control. And if there's poor technique, there's increased risk of glaucoma progression or treatment advancement to incisional surgery. So we can really prevent further progression and prevent the need for surgery just by controlling the technique. So in summary, let me go over a few things here. We talked about keys tonight. And just like keys, each key is unique for the lock it's trying to open. These are principles or things to consider for each patient that's also unique. We want to make sure that as providers and patients are sufficient awareness, making sure we do what we can in the exam room to have a systematic evaluation of the optic nerve. Making sure that we're looking more beyond eye pressure readings. Sufficient action, making sure that the patients, if they're diagnosed, they're treated sufficiently. The pressures are low enough for reaching our target pressure based on the stage and age of the patient. And then making sure there's adherence related to this treatment. They were trying to identify the barriers in a non-judgmental way, in a collaborative way with the patient to help overcome those barriers. So in summary, as we look at this, patients don't see a black tunnel. They don't see the black parts. They see missing parts. I think if patients can understand that, we can all look at the optic nerve like a glaucoma specialist. This is something we can do. And if we rely on the optic nerve more than eye pressures, we can pick it up earlier. In fact, if we can put all the tests we do in the context of the optic nerve evaluation, that increases our certainty. And once we decide on treatment, what's the age and stage? Where are they at on this slope? What can we do to help prevent further vision loss while they're living? And then start go, push start. Have a collaborative approach and then repeat. And while doing so, be mindful of patient adherence, making sure they understand that and identifying any barriers. And then as a provider with the patient, working around that those barriers to help provide the results they're looking for. Let's see, this is, in conclusion, here's an interesting book about insights of how we see ourselves and how we see others. And hopefully from tonight, you've had a little bit of time to reflect. He talked about a technique called a stop, start, continue pattern. And basically, from what you've heard tonight, what should we or I start doing? Maybe it's putting less reliance on the intraocular pressure reading, looking at it after I look at the optic nerve. Maybe it's asking better patient adherence questions so we understand what their barriers are. What should I stop doing? Maybe that's where we stop relying on the intraocular pressure, or stop ignoring the patient when they're asking questions, have a better provider attitude to help improve the patient attitude. And what should we continue doing? I think if we can do these things, that helps provide better care. We can have the best equipment, the best drops, but we really want to be better providers and provide better care. And that takes some time for reflection. So I invite you to think about what things you learned tonight of those different 3 keys. What could we do better at? What should we improve upon? What should we stop? If you have any questions, feel free to email me back. And I do have a little really nerdy site on the web, on the internet, and also on Instagram that has different cases. On this Instagram account, specifically by intention, I try not to have intraocular pressures on any of the cases. I just wanted to get good, make sure we can get it good as providers of evaluating the optic nerve in a systematic way. So I invite you to join that as well. But I want to thank you for your coming out tonight. Hope this was helpful. And as we just think about these 3 keys, I really feel like we can help prevent functional blindness from glaucoma going forward. And as ODs, as colleague to colleague, that's our role. So thank you so much for joining in, for your questions and comments.
Thank you, Austin. I thought that was a terrific presentation on something that kind of gets overlooked. I thought you had some great insight, and you certainly had a lot of literature support. I thought it was a tremendous presentation. So thank you very, very much.
Yeah, I agree, Austin. I think, hitting that IOP, I think if we would eliminate IOP, we'd probably treat glaucoma probably more aggressive in some cases, because even when we start treatment and we get to that target, I think we get to that comfort level. So I think we need to look at IOP as a blessing and a curse all at the same time. So
That's a great way to look at it. Not over rely on it. Yep.
So if you can go ahead and stop sharing, let me go ahead and share the slides
So
one more time. We've done that well tonight. We know how to do that together. So, all right. So we've addressed all the questions here. We just want to thank everyone for attending Keys to Preserving Vision in Glaucoma. This was a synchronous virtual course. Austin, thank you again for doing this. I'm not seeing the chat box anymore since I started sharing. I'm sure the virtual round of applause is starting to come in here again. Thank you for doing this.
it's a
And
pleasure,
you're
and
entirely
honor. Thank
correct
you so
about
much for
that.
the invite.
You're entirely correct. He's getting his round of applause. I think everybody really appreciated. I know I certainly did. Thank you very much, Austin.
Thanks, Joe. Thanks, Greg. Thanks to everyone for attending. Have a great night.
Good night now.